Morning. We're going to look at the challenging problem of proximal tibial fractures and try to help in the decision-making about when to use a plate and perhaps when to consider using an intramedullary nail. We really want to know, is there a difference? I mean, it has tremendous clinical implications related to knee pain, union, malalignment, and infections, implant removal, etc. There aren't, surprisingly, lots and lots of literature on good randomized prospective controlled trials. One of our own faculty, Roy Sanders, and his group did publish something. It's now 7 or 8 years old. It wasn't a randomized controlled trial, but they looked at 22 nails and 34 plates, and actually they found very similar rates. So there wasn't a distinct advantage with either method of treatment, assuming that you did it correctly, or in outcome measures. Most of the common deformities are slight apex anterior malreduction in both groups, and surprisingly, plate removal was more common than nail removal, although many times you don't have to take out the nail, but a couple of the interlocking screws. So when we talk about plates in the proximal tibia, I'm talking about the modern concepts of plating, which are MIPO, and MIPO stands for minimally invasive plate or percutaneous plate osteosynthesis. Sometimes you'll just see it with one P, so it's minimally invasive plate osteosynthesis. And the whole theory and concept of this is to minimize the surgical footprint so that we hopefully, at least again in theory, can promote healing, decrease infection, and then lead to better outcomes. And the whole concept has evolved over the past 20 years. We have better understanding of the soft tissue envelopes and corridors where we can place plates. We have better implants. There's now periarticular plates for virtually every bone in the body, and we have better adjunctive reduction tools and better imaging, and the outcomes hopefully are better. There are a couple of basic principles that don't change. So when you're dealing with an articular surface, you need to get the articular surface reduced, and that part you have to do whatever you have to do. If you've got to make a bigger incision for the articular surface reduction, you do that and get it really stably fixed so that we can move the joint relatively early. However, beyond the joint, in the metadiaphyseal area, we don't have to routinely expose the fracture. We can use controlled distraction, and this is the MIPO part, the minimally invasive portion. I think that there's 4 extremely strong indications for MIPO plating, and they're probably the same for a nail, and they are severe soft tissue injury. So nobody in this room would want to make big incisions in that proximal tibia. That's just an invitation for a wound dehiscence, wound breakdown, and a problem. The other is the complex fracture patterns. Eventually, you have patients with very complex injuries where you just can't put in a nail. Perhaps a fine wire fixator in this kind of case might be a good option, but this isn't something that we could nail. Number 3 are for periprosthetic fractures. We don't see them as much around the tibia, but occasionally you'll get someone with a fracture on a prosthesis, less common than the femur. And then lastly, eventually, even in our hands, you run out of real estate. You just can't nail every single one, and you figure that a plate is a better option. MIPO works better on acute fractures. They don't work on stale fractures, so it implies that you can move the pieces around a little bit with controlled distraction. You need a reducible fracture. If you've got something where it's incarcerated, it's buttonholed through the fascia, and you can't reduce it, obviously you need to make an incision. And you really need to understand the anatomy, and we'll talk about that in a second. And when you do these techniques, you need high-quality intraoperative imaging. So your preoperative planning for a proximal tibial MIPO, or you'll hear from Andy Schmidt in a moment, no different in the distal tibia or the proximal or distal femur, is you need to think about patient positioning, and you want to create a very stable platform using bone foam or some really bumped up legs so that it doesn't move, and you need unobstructed lateral imaging. And the key part that you have to learn is you want to move the C-arm and not the leg. So when you're doing some of these reduction maneuvers, you don't want to have to lift the leg up and have it sag or lose your alignment. So it's really important that you have a stable platform. Surgical drawings are always helpful. You saw yesterday I dig out some drawings from years gone by from older cases, and then it's helpful but not essential to have some of the modern tools that we use today, which are periarticular plates that come with special aiming and arming devices, and then there's a variety of reduction tools. I want to show one concept in one slide on the next 7. So the operative sequence is 1, first, articular reduction. So we're going to try to get the joint reduced. If it's just a couple of cracks and we can put on some clamps and get some percutaneous screws in there, that's ideal. If the joint is disrupted, depressed, it requires a direct open reduction and internal fixation. Step number 2, and this is crucial when doing this thing, and that is what I call controlled distraction. So we want to restore as much indirectly as possible through traction using a femoral distractor or an X fix to help restore our overall length and alignment. And by doing so, it sometimes needs some adjunctive technique. Sometimes with it relatively out, you might have a little residual varus or valgus that with just some manual traction we can help overcome. But in other cases, you need some other additional tools. So sometimes you need an additional femoral distractor or a X-Fix, placing a strategic bump, some joysticks, or an articulated compression distraction device. And then sometimes the periarticular plate itself can help you reduce the fracture. It can be a template or a mold. And then you need to understand your deforming forces, depending on the bone you're working on. So in the proximal tibia, what are we fighting? We're fighting the patellar tendon, the extensor mechanism, and then the eccentric pull. The anterior and lateral compartments are going to want to pull that into valgus, pull it into valgus. And then we do the next step is the submuscular plating. We're going to try to make a very small incision up in that proximal anterolateral portion of the proximal tibia with a cob or some type of elevator, create a corridor to slide the plate down the lateral aspect of the leg, and we want to span the zones of comminution. And we use long plates and spaced screws, and we're looking for balanced fixation. So if we have some screws in the proximal portion of the tibia, you don't need a long plate with 18 screws. You need a longish plate with balanced fixation. We can skip some screws, and depending on the bone quality, it determines the number of screws. So again, we want controlled distraction, anatomically specific plates. We need good reduction tools. It's helpful to have a skilled assistant with maintaining some of the reductions, and again, high quality image. Remember that MIPO is a concept, it's not a technique. You don't ask the scrub tech, I need that MIPO plate. It's an idea that we're going to use. So just a couple of them. Start with easy cases: extra-articular proximal tibia fracture, slid down through a smallest incision. Fix the proximal tibia, a screw in the distal fragment to help coapt or suck down the plate to the bone. That allows you to put an interfragmentary screw in the butterfly piece, and then go on to heal. This is a patient, not such a bad-looking tibia, kind of looked at it, got a CT scan, and the CT showed intra-articular involvement, and kind of reluctant to go ahead and do a tibial nailing, although I think today perhaps we could do that. Anyways, had a MIPO plating. You could see 2-year follow-up, little touch anterior on the plate. Last plating case, patient with an ipsilateral plateau and a tibial shaft. CT shows there's a long connection on a spiral fracture, raft plating above, and a submuscular plating. Again, grade 1 open tibia, washed out, MIPO plating leading to a good outcome. Well, let's just finish up in the last 3-4 minutes and talk about IM nailing in the proximal portion. Dr. Semich is also going to cover some of these concepts. Again, in my 30-plus years of treating injured limbs and fracture patients, I'm highly attracted. So I'm a person that all the residents know we have a couple of rules, and that's you nail in the lower extremity and you plate in the upper extremity unless you have a good reason to do otherwise. And there are plenty of other reasons. It's not every single case. But the reason we like it so much is it's a load-sharing implant. It's a load-sharing implant, and it's still biologically friendly. The problem in the proximal tibia is when we do classic infrapatellar nailing, you flex the knee over a triangle, is you get predictable deformities. It shouldn't be a surprise that you have some flexion or apex anterior, the distal fragment sags posteriorly and translates, and you have a valgus deformity because we know of the pull of the patellar tendon in the anterolateral compartment. And nailing in the proximal tibia is challenging as well because we're dealing with a very short segment. It has a wide, or really not a medullary canal, thin metaphyseal cortex, the deformity factors that we talked about. But again, unlike in the diaphysis, the nail can't help you reduce the fracture. So you have a mid-third tibia, even with a butterfly or some comminution, as the nail comes down and engages the cortices, it helps indirectly. It's the ultimate indirect reduction tool. So what are some of the techniques you can use to overcome deformity? We'll just quickly go through. Is most efficacious in my experience over the last 10 years has been moving away from infrapatellar nailing to suprapatellar nailing, and by doing so it allows you to extend the knee. So without having to hyperflex the knee over an aluminum or a radial lucent triangle, we can now do it in an extended or semi-extended fashion, and it helps enormously. You need to have the appropriate instrumentation that will allow you to do this. I'm not going to go into the technique of doing it. You need to have correct starting points. So with proximal tibial fractures, we often will move our start point just a little bit more lateral to overcome some of the predictable deformities. However, if you have an anatomic reduction, you can pretty much get it where you want to. Again, you need to have modern tibial nails. So the older tibial nails had a Herzog bend further down, and that created an iatrogenic deformity. So we now need tibial nails that have a very proximal bend to avoid an iatrogenic, surgeon-induced, implant-induced. The other things that we found very, very helpful in selected tibial fractures are percutaneous reduction tools and techniques, and we use a lot of percutaneous clamps. In the old days, I used some unicortical plates. I'm going to show you one example. Blocking screws are particularly helpful in very proximal and distal fractures to help guide the implant to maintain your alignment. Again, in many cases, even in proximal distal tibias, we'll use distractors or X-fixes as a means of maintaining that alignment. And again, I can't emphasize enough how important it is to have high quality imaging with the leg elevated so you're not fighting the uninvolved down leg. So a couple of key technical issues is we like to reduce the fracture before nailing. If you ream the tibia with it malaligned, the nail's going to follow the reaming path and you're going to have a malaligned tibia. So you need to maintain that reduction throughout the entire case. You want to maintain the reduction until you get your proximal and distal locking screws before you take out any of your adjunctive reduction tools and techniques. Just a couple of cases. It's a patient that I actually did way back in the 1990s, and the nice part is that I used a unicortical plate. Obviously, we don't have an ideal start point for even a mid-third tibia that's too distal, but way back in the day on the learning curve, we did that, and I actually saw him. He brought his wife in to see me a couple months ago, and there's his 18-year follow-up of his tibia fracture with that unicortical plate. It's gone on to heal. Again, we use a lot of these percutaneous reduction techniques. Segmental fracture, got that long kind of Powell's vertical shear fracture. You know that the guide wire wants to go right out the back. By placing a strategic clamp, you can close that down and then go ahead and put in a intramedullary nail. Similar case, looks the same, but a different patient. Again, careful, small incisions. We now know that this does not compromise the full benefit of a closed nailing. Most of the reaming products still stay there through a couple centimeter incisions on each side. And again, I mean, it's the same story of reduction, careful technique, follow the steps that we talk about, perfect start points, drop down a nail. And this one, we distracted it. You can see to the left at the fracture site. So we locked distally and then we back slapped, and you can see how we compressed and closed the fracture. So I think there's a couple of preventable problems with nailing. If you don't understand some of the anatomy, or you are trying to quickly do the procedure, and you'll end up with a malaligned or malrotated fracture, higher incidence of fixation failures, and non-unions. I think IM nailing of the proximal tibia can be particularly challenging. If you don't do a lot of tibial nailing, I would suggest you try to either learn more or even consider alternative techniques. Thank you very much.